that we need to prevent first ulcer. We need to heal ulcer if at all they have presented with ulcer, and we need to prevent the healed ulcer. Recurrence has to be prevented. Above-knee, below-knee amputations, mortalities and morbidities are high because of delay from the primary or secondary care centers to the tertiary care centers. It could be because of incomplete surgical or medical managements, or it could be usage, incomplete or random usage of the antibiotics. One of the major achievements in the last 30 years was the recognition of the value of multidisciplinary approach to this complex problem, and we always respect that multidisciplinary team is very, very important in the management of the diabetic foot. As we all aware of the International Working Group Diabetic Foot Guidance, and the latest guidance of 2019 has made it very clear that PAD, peripheral arterial disease, has taken upper hand, and you have to categorize as zero after screening the foot for arterial diseases. And renal foot, the end stage renal disease, has been included as a straightaway high because all these people of CKD are with high risk feet. So they have to be screened or examined meticulously every month and accordingly. Goal has been same to prevent the amputation, and everyone is working on it. And the precision has come up what best can be preserved with a very unique classification, which we call as a Wi-Fi classification, which is equal to TRM classification, what we practice in oncosurgeries. And this includes wound ischemia and foot infection with gradings from 0 to 3. And higher the grade, you know, to understand that you come to a conclusion that there is going to be a lot of difficulty in preserving the limb. And even if we preserve, there is always a functional aspect which is taken into consideration, and we are trying to define, are we doing a justice by preserving the limb, by giving a functional foot? And questions again in the function have been asked 0 to 3. Can he walk in the community? Or can he walk at home? Can he transfer himself, or he's going to be better? So this aspect and what exactly is the presentations, clinical presentations in day-to-day practice. We all know that we have three types of diabetic foot presentations: neuropathic, vascular, neuroischemic. The past, more of a 80% were neuropathic and 20 were vascular. But present, there has been a paradigm shift, and we are seeing more and more of neuroischemic feet, and PD assessment is very important in day-to-day practice. So when you look at International Working Group Diabetic Foot Guidelines, as we are going through some of the aspects of non-surgical and surgical offloading devices, the guidance by the very excellent authors, Sikobus and co-workers and co-authors have made it very clear that integrated foot care has been very effective in preventing first ulcer and recurrent ulcers, and it has been successful in preventing 75% of all diabetic foot ulcers. They have also concluded regarding surgical offloading that exact role of these surgical procedures compared with conservative approaches in the prevention of ulceration is still unclear and requires appropriately designed controlled studies. With our excellent team of Association of Diabetic Foot Surgeons, wherein they came out with our excellent work, where surgery for the diabetic foot is a key component of care. And after going through this details of this, they have made it very clear that surgery for acute and chronic diabetic foot problems has long been an integral component of care. Effective surgical management of the diabetic foot remains an integral component of care, as well as for the prevention of recurrent ulcerations. So it is very important, but the conclusion by all these authors, they have made it very clear that successful outcomes of surgery require multidisciplinary team to holistically manage the entire patient, which is very important. Orthotic and prosthetic should collaborate with the surgeons to provide optimal footwear and bracing and offloading after healing has occurred. Ongoing surveillance at regular intervals by this multidisciplinary team as a part of integrated prevention oriented program is very important. Looking at one more work uh, by Aharon and co-workers, the surgical offloading procedures and non-surgical offloading procedures, the comparison and the discussion comes out that while preventive medicine is usually considered to be a superior approach to treating disease already manifested, little research has been invested in DFO prevention. In diabetic patients prior to the first ulcer, how much to invest in prevention is a legitimate question, as most patients will not develop ulcers. By the time they develop, uh, they are grouped into three high risk, and within 2 years, they end up with another ulcer, 50% of them, and 36% of them end up with amputation. So we need a good RCTs to decide on surgical offloading techniques. When we go through the guidelines on usage of interventions to enhance healing of chronic foot ulcers in diabetes under the leadership of uh, Professor J.V. Raymond and co-authors, it is made very clear that all the considerations to recognize these recommendations have been based on studies conducted in specialist multidisciplinary foot clinics, mostly in the first world countries. Their applicability outside these settings, in particular, where there are limitations of human and financial resources, and there may be impact on ulcer healing. So these points have to be kept in mind before getting into any of the recommendations. Recurrences, over 40% of DFUs will recur in 1 year, 65% within 5 years. The reasons being patient behaviors, biomechanics, and ulcer healing and quality of tissue which has healed in ulcer will influence the recurrence. When I was going through this, one of the good workup and paper by exploring concepts in surgical offloading from current IWGDF guidelines, they have made it very clear the problem doesn't end with healing and offloading. Healed foot ulcers frequently recur. This requires a collective refocus from acute offloading to long-term preventing offloading. So the conclusion is fixed offloading devices have superior efficacy. Heel ulcers remain difficult to treat till now, and all other fixed non-removable offloading devices are judged against TCC. And today, a removable knee high has taken up the upper hand, and it gives excellent results as TCC. So TCC doesn't remain a gold standard now. The exact offloading capability of each is not fully known. So ongoing surveillance by multidisciplinary team management is a key. Now, looking at all these aspects, we have come to a conclusion that the treatment strategies need to be progressive for long-term offloading, and we must consider surgical interventions to mechanically stabilize and harmonize the foot. So we know that we have a classification of diabetic foot surgeries. So these surgeries are of different types. Elective and prophylactic are very, very important, and curative what we opt for healing of the wounds. So these versus non-surgical offloading has to be thought of. And when we go through this protocol, non-surgical offloading, which has been made very clear to all of us that persons with diabetes, neuropathy, and a foot ulcer has been categorized in a broader three groups: non-plantar ulcer, plantar forefoot and midfoot ulcers, and plantar heel ulcers. The plantar forefoot and midfoot have been again categorized into two groups: infection or ischemia present, no infection or no ischemia present. And accordingly, if with all these modalities of offloading devices like non-removable knee high, removable knee high, ankle high, felted foam, and appropriately fitting footwears, if there is no healing, then only the patient is subjected for surgical offloading. So let us go with the evidence what exactly we have done in our setup. We planned a patellar tendon brace for non-plantar ulcer, wherein a lady a 55-year-old chronic non-healing DFU on lateral dorsum of the foot, where you can very well appreciate there is a various deformity with ankle subluxation, unable to walk due to there is a projection of lower end of the bones through the wound, and this was a case of acute Charcot, treated as cellulitis, and they went for a release incision. Since then, it is non-healing. Patient is very poor with peripheral neuropathy and anemia, and she can't afford any kind of surgical management. So we planned for non-surgical offloading, where we went for a PTV, and you can see excellent healing. And the patient was later placed in a crochet, and she has a good quality of life, and she doesn't remove crochet whenever she is ambulatory or weight bearing. Removable ankle high cast for forefoot ulcers. A patient who has undergone forefoot amputation, 65-year-old male, diabetic since 15 years, with peripheral neuropathy and PVD, DFI, and underwent forefoot amputation. And there is a chronic non-healing DFU since 1 year. And he is suffering from bilateral diabetic foot, where he has a DFU at the first metatarsal on the left side also. We planned a non-surgical offloading device for this patient, wherein a knee-high removable ankle high removable cast was planned, and you can see the excellent healing of the forefoot ulcer, which could have been treated with TL, but because of the patient conditions and cost effectiveness, we planned this and we could achieve this healing. So removable ankle high cast for a midfoot plantar ulcer, a patient, a 48-year-old male, diabetic since 10 years, peripheral neuropathy, CKD anemia, chronic non-healing DFU and midfoot. Patient is very poor, and we designed this healing with non-surgical offloading, and you could appreciate that excellent healing. And he was given customized again crochet, and patient is absolutely back to normal to his activities. Removable ankle high offloading device for the heel ulcers. A 60-year-old lady, diabetic since 13 years, hypertensive IHP with obesity, peripheral neuropathy, chronic non-healing heel DFU. We designed a non-surgical offloading device wherein patient could respond very well, and we could appreciate a good healing at the heel ulcers, and later the patient could advise uh, customized crochets, and patient has excellent quality of life. Now, forefoot ulcers, where we designed some of the modifications in the footwear because they were not compliant for the casting. So we had to plan for this patient who had a rigid foot and who was very poor, and he had a first MTPJ chronic DFU. So we had a footwear assessment, and we could notice that there was a lot of plantar pressure at the first MTP area. So we designed a silicone insole cut, which is very costing them very minimal cost, like less than 15 rupees from the entire silicone insole, and we placed it there, and we could achieve excellent healing where patient was told to use it continuously. He was told not to be barefooted. Now let us know if we don't have a right approach after surgery, like what it has been done over here for DFI. They planned an excellent flap surgeries, and they could achieve excellent limb salvage. But once the patient starts walking, and if there is no long-term offloading planning for these devices for these kind of surgeries, they end up with ulceration because diabetic foot is insensate. So this patient came to us for designing of a footwear, where we have to design a footwear where we could offload the heel. So DFU recurrence with poor quality of life is possible if we don't plan for long-term offloading. One more patient was referred to a center for the footwear designing because they had done this flap surgeries for the dorsum, and the patient, within no time, within 6 months, he developed again plantar ulcer, and it was very difficult for us to brace the footwear because of the bulky muscle which was there on the dorsum. So these are the uh, basic difficulties what we face if we don't plan biomechanical uh, salvage of a limb, or how best it is biomechanically um, going to be normal. And we need to plan long-term offloading devices for all such procedures when we plan a surgical offload. So let us look at the role of a rural surgeon. Every rural surgeon has to improve his care, protection, and referring zone to the higher center according to the patient, whoever he has received in day-to-day practice. Early reference to tertiary care is very, very important to reduce the complications, avoid incomplete surgeries, avoid incomplete and random usage of antibiotics. Developing team approach is very important for them. Long-term offloading devices has to be thought of. Vascular assessment is very, very important, and it has to be practiced in day-to-day practice. Complicated DFU, non-complicated DFUs, you have to plan in poor resource settings, non-surgical offloading. As all of us know, the management of DF is very clear with six cornerstones with metabolic care, vascular care, microbiological care, wound care, mechanical, and the most important is education to the patient, to the relations, to everyone, so that the recurrence can be avoided. Take home message. Don't plan prophylactic surgery if there is a PVD. If you don't have a long-term offloading device, if the patient is non-compliant, if you are in a resource poor settings and you are working on a rigid feet where there is rigid empty, first empty PJ and rigid ankle, DF with multiple comorbidities, please avoid prophylactic surgeries. TCC and footwear modifications can heal DFUs.
அந்த ஃபுல் பேர் வந்து ஸ்ரீதேவி ஸ்ரீதேவி 24 இயர்ஸ் கொடுத்தேன் மீட்டிங் போயிட்டு இருக்கும்போது கேன்சல் ஆகிடுச்சு என்னமா இவங்களோட ஆச்சரியம் இருக்குது சாரின்னு போடுறேன் ஐயோ